might seem scary, and I think the term clinical academic in itself can seem a bit scary, but it's basically a nurse or a midwife who has followed an academic career, but they're still very much working in the clinical setting. And you will hear today from Kaz, Julie, and Katie around where their jobs are placed and how they fit in with clinical care. They are very much feet on the ground nurses, and they're all driven by a passion to improve care. They're role models, and they demonstrate how rewarding and how relevant being a clinical academic can be. So our presentation today is pretty relaxed. We're going to basically get the speakers to tell their stories, and then there will be some time for you to ask questions of them afterwards. The next slide, I don't know if you want to just put that up, Damon. It just shows you on Future NHS where to find more information about clinical academics and how to get into this. I will give a quick health warning. When you start looking at this page, you will find many meanders and rabbit holes and interesting things to look at, but it will give you a chance to find out where to find out more today. So you can just sit back and enjoy this. It is being recorded, so you can come back to it or share it with your friends. Okay. So I think without further ado, we'll turn first to Dr. Kaz Shotter-Wheatman, who's, I'm very pleased to say, is a colleague of mine at West Middlesex Hospital. And I'll let her introduce herself and tell you a little bit about her career. Over to you, Kaz.
Thank you very much, Chris. Thank you to everyone who's attending today. It's great to see so many people. We've got a lot to share. I'd like to start by telling you what I do. I'm a lead advanced practitioner in cardiology, very much on the ground. I run clinics looking after patients who have coronary artery disease. So that's very much part of my working week. I develop the plans for these patients and order diagnostics, amend medications, and then send the treatment plan through to the GPs, and I will see them again if it's necessary. And I've been running this clinic since 2001, and we were one of the first ever nurse-led clinics to set up, so we're really quite proud that we've managed it. I'm also a mentor to the cardiology team, nurses particularly, and will visit the ward if needs be. And I have a finger in lots of different pies, is what happens, and also divisional lead for in research for our emergency and integrated care. So a little bit about me. I trained in the early 80s, and like many of us, worked my way up through the ranks. And the first time I ever looked at exploring anything to do with research was when I undertook a diploma. There was no university nursing when I trained. A diploma in rehabilitation counselling, the first ever in Europe. And it really opened my eyes and made me really inquire about research methodology at the time. And I also was working to increase and develop myself in my career. So the specialist nurse role really took hand. I don't know if you will remember, some of you will. We really started to develop in the early 80s. That's when this all happened. And so clinical nurse specialists were seen as, really going to change the face and scenery of nursing, specialist nursing. And I believe many of us have tried really hard to do that. From there, I went on to do a master's in science in that particular field in cardiology, and trying to manage work and private life was a little bit difficult, but managed it, really enjoyed it, and then settled back a bit, sagged back and thought that's great, until I was approached to do my PhD. And at that time was very nervous, didn't really know what to do, where to go. And there was very few people around to support you. But I grabbed it by the horns and decided that, it was something I could do. very fortunate to get funding, literally begged for funding everywhere. And people were very generous, so that was superb. Ended up getting my PhD in 2017, and I'm really, really pleased that I did it. It's taught me an incredible amount, and the research part has enabled me to do so many things in my career. And I really enjoy sharing what I've done with our staff and encouraging them and trying to mentor and offer courage to get onto this clinical academic scene and believe that you can. It's a bit daunting, without a doubt. It's really daunting. But I think with support and knowing where to go in the signposting, and Nicola's popped something in the chat, which is fantastic. It helps us to look broadly at what's available to us. I think a few things that I would say to you is, you will be nervous when you start out, but it's okay. It is okay. You can get there. Persevering will be important. Belief in self and getting as much support as you can around you is absolutely essential. And just with an evidence-based practice head on, I'd say we have to start from that base. So our evidence-based practice is in front of us, and whatever we do, we have to work from that base. I've been very, very lucky to have achieved what I've achieved, and I continue to work in this role, very motivated to looking after our patients. I'm very involved in patient stories and narratives. I believe in the patient story, and I don't feel we can do much else if we haven't heard their story. So, I will continue working in the clinical area. Have had many opportunities to move out of it, but I've chosen to stay, and I'm really pleased I have. Thank you very much for listening. Thank you.
Thank you, Kaz. And yes, I can vouch for the fact that Kaz has a real influence. She is a real role model within our trust, and West Middlesex is part of our trust that's very much based as it's a district general hospital. And I know it's very much appreciated. And as you know, and it's great to have a nurse who has achieved this, and they particularly, and I'm the same vintage as Cass, so we didn't sort of come into a graduate profession, so it's quite a scramble to get up there, but it is well worth it. So next we've gone from cardiology. I'm going to pounce on you, Katie. Cardiology and maybe sort of some of the older population, shooting right back down now to the younger population at the beginning of the birth. So it's a pleasure to introduce Dr. Katie Gallagher.
Nice to see you all. I don't know, Declan, if you wanted to stop screen sharing so maybe people can see us a bit. Not that I want to be on screen, but just so we can. Oh, perfect. Thank you. Nice to meet you all. Thank you, Christine. So, like I said, I'm Katie. I am a neonatal nurse and I work between UCL and UCLH. And I think probably what I'll do is just give you a brief background of where I've come from and then what I currently do, so you can get an idea of a kind of a different side of an academic role. Because I think one thing when we chatted amongst ourselves when we were talking about doing this webinar is that whilst we're all technically classed as clinical academics, we all have very different roles, which makes it good because it means that because we don't really have a very structured career pathway, we can kind of personalize it and make it what we want it to be. But it does also then make it quite tricky because it means that you don't always have something that you can mirror when looking at others to say, right, that's the pathway I want to do. It's very much kind of pushing yourself forward a little bit. So I did my PhD back in 2010. The thing that kind of motivated me to do it was I've always been interested in providing end-of-life care for babies on neonatal units. I witnessed practice back in 2010. I would love to say had changed now in 2024, but unfortunately I think we probably still have only a little bit more evidence for how to provide good end-of-life care now than we did then. And for me, it's always about how we can engage the families and how we can support healthcare professionals to provide end-of-life care in the neonatal unit. And that's what kind of has pulled me all the way throughout my career. So whatever I do in terms of working with nurses on the ward, that's my kind of own personal programme of research, is looking at how we can improve that aspect of care. So when I did my PhD, unfortunately, there still weren't particularly structured career pathways. It was very much, if you'd done a PhD, the NHS didn't quite know what to do with you. So most people just generally go into university education. And so that's what I did. I was a lecturer over at King's. So I helped design and implement the postgrad diploma in children's nursing. And unfortunately, my only kind of clinical work then was working as a clinical mentor to the students over in practice. So I had to step outside of clinical practice at that point. I spent some time abroad working in the States. I was part of the American Neonatal Nurse Association over there. So still kind of maintaining that link with practice from the kind of health professionals perspective. And then when I came back, I followed a much more kind of traditional academic route. I worked over at UCL, where one of my mentors I've always kept in contact with went to work over there as part of a programme of research looking at, again, very much focused around antenatal and neonatal services. But whilst I was there, one of the things that I've really wanted to kind of go back to was my roots, was to think about how I can get a foot back in the door in practice. Because I really do believe, as a researcher, unless you're on the floor identifying what's going on in practice, then you're not going to pick up those things that really we can make a difference to in nursing. So it was very much around shoehorning myself in. And we have an amazing matron on the unit who was very, very supportive of me, but going back into practice, but being very clear with what my role is. So I am not an advanced nurse practitioner. My research skills are my strength, and that's what I do. And I know that's what I do well. My clinical skills, if I was to go back into clinical practice, I'd have to go back and do a period of consolidation and get those back up to speed. But I know what's going on the unit. I understand the basics of the nursing care. I know what's happening. I know what the parents go through. Well, not directly, obviously, but I know their journey through the neonatal unit. So I'm very aware of what's happening. So my role in practice now is working with the nurses to say, okay, so this is what you're doing on a day-to-day level. What do you think needs to be improved? What do you think needs to be enhanced? And my role is to help them develop those research projects. So I'm all about developing capacity and capability in nursing research. So I've helped the nurses. We do projects around, we did one around organ donation, for example. We were very aware that on the unit, we don't necessarily offer neonatal organ donation. So we did an audit to look at the past 10 years and how often referrals have been made to the SNODs. And therefore, what do we need to do moving forward? We did a survey that looked at staff knowledge and staff competence and found that actually most people don't know what babies can actually donate in the neonatal unit. So we've got a programme of education that we're implementing with the SNODs to address those things. We've done research around documentation. So we're currently doing a retrospective chart review at the moment that's looking at what do we document during admission of babies onto the neonatal unit and what are we missing? What do we need to improve? And we've literally been going through the results this morning, and one of the things that it's very clear is that we don't document is actually the partner's name. And we know that in theory, in practice, but actually seeing the numbers in front of you and seeing, well, we've got 200 babies that were admitted, and actually we only documented the partner's name in 43 of those charts is quite sobering. Another one of the projects that we've done, so we do smaller projects like that, but then I also try, one of my aims is to really try and bring the teams together. So one of the projects that we've just managed to get funding for is to look at how often we bath babies on the neonatal unit. And this is a project that we were having a staff room conversation about. And, you know, I said, well, there's some funding from the NIHR, and it's specifically for nurses and midwives. So what is it? If you could do anything, what would you want to do? And the big thing that came out was about bathing babies, about the fact that we don't really bath babies that frequently anymore on the neonatal unit. And why don't we do that? And actually seeing baby skin colonisation and families that don't feel ready to be discharged. So how can we change that? So we put together a grant application for the RFPB for the NIHR. and were recently awarded just over 250,000 to do a feasibility study to explore how frequently we should bath babies on the neonatal unit. And that came from just being embedded with the team in the staff room, talking about what it is, do you want to change, do you want to happen on the neonatal unit? So in terms of what a nursing academic can bring to your unit, to what happens in clinical practice, it's very much thinking about, for me, like I say, for our team, it's helping to support people to do their own research. I want other nurses to have better support and career structure than what we had 20 years ago, when there's essentially nothing, you know. And if we can help to support nurses through that and to give them some role models and to say, look, if you're interested in research, if you want to do this particular project about something, great, let me help you. Here's how you make a start. Here's how you go about that. Then absolutely fantastic. You know, that would be amazing to be able to see some more nurses being able to do that. So that's a little about me. That's about my role. I hope that was helpful. And yeah, thank you very much.
Thank you, Katie, and it was really helpful, and I'm so glad you told the story about bathing the babies. Obviously, my midwife background, that is important, and I think it just demonstrates the same as what Kaz is saying. It builds on that about listening to the patients and how nurses can and should be researchers, and how it can be very much embedded in clinical practice, the sort of clinical practice that we all recognize, you know. And this is something that wouldn't necessarily be picked up by colleagues. And I noticed that we've got, you know, I'm talking about nurses and midwives, but also allied healthcare professionals, MMAPs, and we have a part to play in research. And I think there'd be a big gap between what our medical colleagues do, and a lot of that is a patient-based gap. And as you say, things like partners' names and things, the things that we think are happening and they're not happening. So that's really important. So thank you so much for that. And please keep sort of questions in your mind, because we've got one more speaker to go, and then it will be an open floor for questions. I know that I've certainly got a couple sort of buzzing around. Moving on then to Julie, Dr. Julie Menzies from Bristol, and again, looking at sort of things from a paediatric point of view, but again, another story and another individual example of the, you know, the fulfilling role of being a clinical academic. So over to you, Julie.
Yeah, thank you so much. Yes, I'm here talking actually from, and this is just an example of where I sit as an academic. So actually my office is just on the main corridor into paediatric intensive care. So if there is any background noise, I am on the main thoroughfare through, just off it. So apologies for any noise. But that's exactly where we should be. We want to be embedded in clinical areas. That's the whole purpose of these jobs. And it can be really tricky, because often when you're in a non-patient facing role, you get put away in an office. If you've got some desk space, that's another challenge, away from patient areas. But actually moving into this position, just being off the main corridor, has been fantastic for me, because I get everybody sticking their head in. I get people popping in to say, I have a question, or I was just thinking about this, or, ooh, I've done this piece of work and I now want to think about how I can write it up. And that's exactly the kind of traffic I want to come to my door. So yes, I'm Julie Menzies. I'm a clinical academic nurse researcher. These titles aren't always that user friendly, are they? They don't really kind of capture what it is the job does. And I'm based within Bristol Children's Hospital, which is part of University Hospitals Bristol and Weston. My job description is very much cited within the Children's Hospital. However, actually, I've just come from a meeting talking about support we've been doing, which is across the trust. So for me, I don't care really where the boundaries are. Any nurse, midwife, AHP who comes to speak to me about research is more than welcome. If we go to the next slide, Declan, thank you. And just to say, I do have honorary contracts with universities, but I suppose my journey here, as you can see here, is that it's always been very much been situated in the NHS. So again, also on the older side of things. So I did my degree, my master's and my PhD all at the University of Bristol. University of Birmingham, I'll get my words right. And actually most of my clinical career was at Birmingham Women's and Children's Hospital. And I only recently started in the last 18 months here in Bristol. And actually that in itself is a journey, because I'd been wanting a job here for a long time, and we had to have a lot of conversations about what an academic job could offer. So I am quite well versed in trying to work out how we sell these jobs and what we can bring to an organisation. Most of my career is within paediatric ICU. I've done audit roles, I've done, all the kind of clinically based education, tech team retrieval, all of that side of it. And I also did a research nurse role as well. Now, and I think that's another interesting avenue, because some of our research delivery nurses are very happy and they have a career trajectory within research nursing, the delivery of our research studies. And absolutely, we need to work more on career pathways for them. But some people do want to cross over and develop their own research. And again, we need to think about growing people from that pathway as well. So for me, I am one of those people that spanned clinical and research, and my academic sort of knowledge is around operationalizing research in a tricky area. Doing research in paediatric intensive care is quite tricky. Our patients are really sick, our families are in a really stressed situation, but it's actually a really important area to research. If you look nationally, our beds, there are only around about 360 paediatric intensive care beds, which is why every winter you see it in the sort of in the press about how poor children are being moved across the country, because there are immense bed pressures. It's obviously it's really in our patients' best interest that we optimize the care that we give them, and for their families as well. But actually there's not really a very firm evidence base behind a lot of the care that we do. So we're an area ripe for doing research, because it will have direct impact on our patients and it's a scarce resource. So if you just move to the next slide, Declan. Thank you. So this is kind of how my role sits. As I say, I'm an academic within paediatric critical care, HDU areas. But then I actually span across the Faculty of Children's Nurse Education, and I sit within the matron and senior nursing team, and that's the kind of the capacity and capability building bit that Katie alluded to as well. So my academic role is within ITU, and I get that a lot of places on the call may not have these roles. They are relatively expensive to fund. It was a challenge, to sort of justify why they needed an academic role within intensive care. And actually, I'm really hoping now that 18 months in, I'm starting to make the case for what that does bring. I also have roles sort of nationally and internationally, which is great. But the bit that really is benefiting the trust is this kind of capacity and capability building. Again, fancy way of saying that I kind of nag about research at every single meeting that I can, that I think about. I'll talk to anyone about research who wants to talk about it. It's really about driving that kind of engagement, understanding, education, and trying to really create opportunities for all our staff. So yeah, if we move to the next slide, Declan. And this is a slide that I like to use, because I think when we're talking about this capacity capability building, it's like, what does that mean? And how does anybody go about thinking about creating research opportunities? And this is a model that a number of organisations, I know Manchester and I know Nottingham, have got a similar NMAPS model, and they kind of almost break it down to kind of 4 sort of stages to this. So we're thinking about exposure and making research visible. So often when people say there is no scope for these kind of roles in our organisation, but actually they may well be taking part in research. So it's about making sure that the staff in those areas know about the studies that are taking place. Do patients get the opportunity to take part in research? How visible is it? Are staff getting the opportunity to develop their own quality improvement, audit, service evaluation projects? And do they know what the difference is? And what is the best approach to take? I've been involved in some national work looking at trust induction process, and actually there's been an excellent video created here in UHBW recently by our research lead, looking at, it's a really great video about how you can communicate about the research taking place in your organisation, because really we're all saying research active organisations have better outcomes, but what message do people get when they start in your organisation? Do they hear that? Do they hear that you're leading and conducting research? Do they hear about where you go to develop an idea and what opportunities they are? So I think that can be a really kind of key moment that is often overlooked. And then obviously part of my role is about leading my own research and trying to role model that to others to show, I mean, there's a great phrase, isn't there? You can't be what you can't see. And it's really hard if you haven't got people in those roles to go, nurses can lead and develop their own research ideas. So I try to help promote that as an opportunity for people and see that as another kind of career pathway. In terms of engagement, there was some work done around developing resources for undergraduate training material to help people understand what a research career can look like. Those are actually, I believe, on the NHS Futures website now. I'm looking at Nicola as I'm saying that. That resource should be available on the NHS Futures site. And there's a paper about that work as well. But another opportunity is to engage undergraduates from nursing students in work in the NHS, so they see what clinical research can look like. The NIHR has recently funded some internships to actually kind of help people create more of those opportunities. I think secondments and split posts are a great way for people to get some understanding and engagement in research and try it out and see whether it's something that could be for them. And I help to kind of promote those roles. I think linking with our ACPs is really key. They've obviously got a core pillar of practice that is research. So how do we help articulate that? What work are they doing? And how can that help we role model that to our other staff? And I think the key thing as well is about having research on every gender. In our trust, there was an NMAPS strategy launched in September last year. And actually our Director of Nursing in our Matrons meeting in the Children's Hospital has now reframed the meeting so that it reflects those 4 pillars of practice within that. So the agenda items are cited under those 4 categories, of which research is one, which has been a great way to get people thinking about what we can talk about in terms of research, even in an operational forum. Education and training, I do lots of kind of tailored support to people wanting to develop their own ideas, write work up, apply for funding, but it's also about signposting to resources that already exist. There's loads of really good resources out there, but you don't know about them if people can't signpost you to them. So even if you don't have an academic in post, it's about bringing all those resources together in one place to help people find that information. And patient and public involvement and engagement support, again, you see it a lot, but often people don't know how to do that, what that can involve. And I see that as a key part of my job to help people understand what that could involve. And then this embedding, I mean, I'm really lucky. I'm speaking here as a research role that is rooted in clinical practice, but I am not pulling up that ladder behind me. I want to create more of those jobs for everybody else. And for people who are interested in this, we've really got to work more. So contributing to our trust strategy, I make a link up in the region about the regional strategy. And it's all that conversation about how do we create more of those jobs and how we build our links with our higher education institutions as well. The universities are kind of over here, we're here, and why aren't we linking up more? I think it's really key. Next slide, please. So just wanted to put in a couple of practical examples about how I feed into the quality, safety, patient experience and staff experience journey. Somebody in my last organisation said to me once, it's great, you know, I can see your role's great, but you know what? That isn't the stuff that I need to talk about when I'm in my senior meetings. So tell me about how you contribute to quality, safety, patient experience and staff experience. And it's a wake-up call for me. They didn't care about the individual projects that I was getting funding for. This was the stuff that was their operational pressures, and they wanted information about how I fed into that. So on the next slide, I've just got a couple of examples. If you're right to go to, yes, thank you, Declan. So for example, quality, we had one of the band 6s on intensive care was challenged with sort of looking at the infusion fluid through central lines and arterial lines. They wanted to make a practice change. They weren't sure whether or not it would be a research project. And actually I helped support her to do a literature search and to do some an audit around current practice. And actually in the end, we decided it didn't make a good research project. So not everything is about research. And actually there's been a practice change, which has been shown to be safe and hopefully will save money. It wasn't me doing the work. I was just there in a supervisory and supportive way, but that was a great learning opportunity for her. And she did great work, took it to a conference, presented 2 abstracts as well. So it's contributed to patient and the organisation, and also to her personal development. From a safety perspective, for example, back in January, I did a service development grant to increase our research cover so we could support staff to learn more about the studies that we were doing that helped reduce adverse events, increase the quality of the research that we were doing, and contribute to safety. Patient experience, we're in the process of setting up a new patient and public involvement database of families that will want to work with us to help inform our research, but also around governance and service development issues. So actually that will hopefully be a really useful resource for the unit moving forward. And then staff experience. I mean, for me, we've really tapping into the kind of recruitment and retention potential of these roles. We've got a workforce now who are coming out of university and saying, what can you offer me? And actually, when we're doing our recruitment, we can now say to them, we can support you to apply for further opportunities. We've got people here who can help advise you on how to take your ideas forward. We've got people in visible posts. Our organisation supports this. So that's really important. And then from a staff retention perspective, actually, it's a new opportunity for our workforce to come, get some funded time, develop their own ideas further. And maybe research isn't the way, it isn't for them. But what I found in the past is that staff often, they go away from it and they go, oh, it's not for me, I'm going back to clinical. And I had a great example of somebody in Birmingham who she did a research nurse role and she developed her own small project on the back of it. And at the end of it, she said, oh, I'm going back to a clinical nurse specialist role. And within a month, she contacted me saying, so I'm seeing all my patients in clinic and I'm spotting that none of them have got really good inhaler technique. And I really want to do an audit, a service evaluation about this. So straight away, everything she had learned was there for her to use. So I don't see that as a loss to research. That is about upskilling our workforce to all be able to engage in it in different ways. So I think from my perspective, I'm hoping I've been able to show a bit more about how we tap into each of those areas. But I just really want to emphasize that it isn't all about a clinical academic. It is about creating opportunities for our whole workforce. And that doesn't mean you need somebody necessarily in a post like mine, but it's about opening our minds to what they can bring when they want to apply for these opportunities. Often we hear that one of the barriers for people applying for funding is that they can't be released to undertake any additional training, even when there is backfill for them. And I absolutely understand those operational pressures. But what my experience is that those people will stay in the organisation when they've been grown and they've been invested in, and actually they're then doing research that's really important to the organisation. I've got somebody who did an undergraduate student placement with me right back in 2017 in Birmingham. She's then gone on and she's gone through several steps and has just submitted a PhD application. And actually the work she's doing is about managing interruptions for medications. And actually that's just so topical, really taps into the patient safety agenda. And it's all because she's remained embedded in clinical areas. We didn't lose her to a university. She's still there. And the work she does is absolutely grounded in the everyday practice of ITU nurses. So hopefully that's been a useful insight into what these roles can bring. Thank you.
Julie, thank you so much. That has been excellent, and and particularly around sort of investing in that workforce, and keeping them in, and we've got examples of that too. Thank you so much. Thank you for your passion and your drive, and it certainly answers one of the questions from that someone who had to go, Dean, who was just talking about linking, and unfortunately he had to go before you started talking about this, linking research to service improvement projects and QI projects as well. And I think you covered that nicely, making that link and how that can add to that. So that is really important. Opening the floor to questions now, if anyone wants to make a start. You're all very quiet. You're all very quiet at the moment. I mean, I've got one. I know when we there's a hand gone up. That's great.
Sorry, hi, I'm full of cold, but I'm not with you in the same room, so that is good. My name is Rahab. I am a third-year PhD student, same hospital as you, Julie. And it was Nick who mentioned your name, so it's good to meet you here, and hopefully we get to meet outside. I think the challenge, Katie was talking about, the lack of pathway, and then losing people to the universities. But I think the options are very limited. I am getting at that stage when I'm looking at what is next, coming to the end of my PhD. And I don't know, unless there is something ready for you, I've heard a comment, did we ask you to do a PhD? Basically, you went on to develop yourself. And sometimes the only option available is actually to leave and start somewhere else, even though you would love to continue with the clinical, you love what you're doing and you want to carry on doing it. But do you stay where you are after doing a PhD? Of course you want to do more. Of course you want to introduce more ideas, more research into your clinical area. But the opportunities are very limited, and I'm thinking this is a challenge. And maybe, I love what I did. I'm doing it with King's College, and I've really enjoyed it, and I will do it all over again, whether there is a job or not. But actually, what can we do to improve the opportunities for people like me?
I was about to pick it up, but actually, I wonder if Katie wants to pick it up first, and I'll come in after.
I think it's a really good question, and it's a challenge that I think a lot of people are having. I know from talking to colleagues just over the road at UCLH. So we have a number of people who are at the same point and are thinking, well, what do I do? Where do I go now? Because like I say, once you've done a PhD in the NHS, it's that struggle of, okay, so what band does that put you on? Does that promote you to a certain band, but does that band then relate to clinical practice? And it's very, very challenging. I think there's a few things that are helping that at the moment and will hopefully continue to boost that in the future. So one obviously is the NIHR. So the NIHR do postdoc funding for nurses, midwives and AHPs, and the funding that they provide covers your salary, and so allows you to have an honorary appointment within the NHS, which means that you can create that role that you would like, and you're almost like a bonus for the ward, because it means that you don't have to have that job match funding from the NHS. You're there, and like I say, you can create your own pathway. It is still a challenge. It was something that I had to struggle with when I got my fellowship in terms of how that was organised, but it is there. I think something that will help with that is there is a group of people based in Nottingham. Julie, I don't know if you're part of this actually, and they're looking at trying to develop ways to evaluate the role of clinical academics in practice and how we can measure it. And so whether we can look at outcomes for patients, financial outcomes, things that really can support us when talking to the senior leadership in the trust, to say these roles are worth it, they do make a difference, and this is how we can measure them. But it is a challenge. I think even finding other people within your trust who are doing PhDs in itself can be quite hard, but creating those networks can be very supportive as well.
I was just going to pick up on that and say, I think there are some pockets of really good work. So I know Julie Sanders' papers around, one of her papers is from Barts, isn't it, actually, looking at planning for your postdoctoral career. And I remember her saying that they start planning for it the moment you start your PhD, which sounds marvellous. I wish that didn't happen for me. I got towards the end of my PhD and it was really like, well, what are you going to do? And I said, well, I'm coming back. And it is hard because you've got all this new knowledge and skills, which clearly you want to use. So I think it is about the organisation planning ahead for you and being clear that those are valuable knowledge and skills, and then thinking about how they can be utilised. For me, it was a small change. So I was a band 7. And I went from being a research sister to being a nurse researcher. And actually I stayed on the same band, but actually just that tweak in the job description, I kept lots of responsibility for overseeing research delivery, but there was just that small tweak, made a difference in terms of that, being able to grow your own ideas and to have a bit more scope to get involved in some of the national work. We're a small specialty, so we have to do lots of collaborative work. And I have to say that is a really key thing, is to collaborative work outside of your own organisations, learning from how other organisations have done it, the the mentorship from others outside, I found really helpful, because I didn't really know what the first steps would look like. And I think that that is changing, and because there is so much more visibility now about these posts. But I completely understand, and I'd be very happy to meet face to face at some point and chat more.
That would be great. Thank you very much. Thank you.
Thank you, Rahab, and thank you, and all the very best with your PhD. Kaz, I didn't know whether you wanted to jump in and say anything else. I know you put a comment there in the chat about mindset change essential, which I agree with. Did you want to add anything to that for Rahab and for everyone else?
Thank you, Chris. I think the point that Kate raised about, perhaps looking at the agenda for change spine, and in particular, job matching and evaluation. I'm a job matcher and evaluate. So if you were to ask me, is this possible? It is more than possible. It needs to be recognised, as Kate, Julie and myself are saying. These posts are not readily available and out there, but they need to be. So this is a change in mindset, and this is us talking to our leaders and those who we need to influence, to say you need these individuals, or you need people who are like-minded, who will do the things that Julie was talking about with reference to quality, safety, patient experience and staff experience. That's what they want. So a bit like you and I were talking, Chris, in our JDs, it often says research in small letters. We need to change that. We need to make research part of our whole work, not just a tiny part of it that we may or may not do. But we can't do that without working together. So, yeah, I mean, so many things I can think about now after the discussion. But this is something we must drive and push. We can't leave it sitting at the side. It's too precious to us, I think. Thank you.
Thanks,
just to pick up on that,
Yeah, go on.
what you were saying there, because I think it's a really good point. And even just between Julie and I, because Julie's obviously sat within the NHS and I'm sat within the university, just seeing each other's job descriptions and what they entail and just sharing them, even on that basic level, is really helpful to think about strategically how we manage our roles and what that scope is and how we can plan for them and evaluate them is really helpful. So even just something like that, if that is useful, is something we can share.
I agree, and I think it's with everything in the health service as well. If you can go and say, "Oh, our trust," if you can say to your chief nurse or to your CEO, "Our trust hasn't got this, but the trust up the road has," and if you can show the value added, both in terms of staff retention and income, I think I've used that quite often, quite shamelessly, and just said, "Look, we haven't got this, and they have." That they want, you do have to use that competition. That's really helpful. Is there another question? Nicola.
A little bit of a question and comment, and I don't think there's an easy answer to it, and we're all trying all the time, but how do you think we can persuade the top to embed clinical academics, for example, in quality improvement teams, CI teams? Because obviously, like, you guys are sort of working like in specialities, and which obviously helps that department thrive and grow and improve. Just thinking for strategically in a trust at the top on how we have lots of quality improvement projects ongoing across the trust, and how can we embed in those teams, because quality improvement is, I know we're going to be talking about this at another webinar, but it's about improving, and obviously research is about using research methodologies to improve. So how do you think we can persuade and enable and embed people, clinical academics, within the QI teams? Question to all.
I might pick up on that one first, actually, because I found that QI has been a great avenue into stimulating people to develop ideas. So often it's people's first step. They've seen something, they want to do something, they take a quality improvement approach to it, and that's great. And actually, I am not. I think of it all as a continuum, and quality improvement, service evaluation, audit, research. And actually, I think it is about some ideas may well start as a QI piece of work, and then actually it opens that floodgates to those next questions that come. So for me, I think it's about tapping into, and a lot of trusts have invested heavily in QI, so that's great. You know, there's a great embedded infrastructure and support around how to do it, you know, and all of that's there. But it's perhaps about finding the people whose projects have got some potential, or the individuals who've got potential, and that's something I want to look at a bit more here. There's a new forum that started here in our trust a few months ago, and I'm seeing every month now lots of ward areas and nurses in particular presenting about QI work they're doing. I want to try and now tap into some of those and go, right, what's the next steps with this? You know, how are you disseminating this further? What are you going to do next? Because the one challenge I think about QI is it's often not sustained. And I think also you need to think about database, so that you don't end up replicating the same pieces of work every year or 2 years. And you need to also learn from each other's experience, which means, again, a database is a really useful way to see who's done some work on this and how can we tap into what you did and learn and improve our approach to it. So I don't necessarily think their person needs to be embedded in the QI service, but you just need those links so that ideas and people and projects can have some legs and go beyond QI.
Thanks, Julie. And I think that's really important about that. I was just scribbling a note there about the database, because that is really important, just to keep track of things. Thank you. Kaz, did you want to jump in there?
Thank you. Just to reiterate, Nicola said, how are you going to? It's almost like, what's the ask? I mean, if it were me, I would be wanting to present to the senior team, but I'd be benchmarking as well. So I'd want to showcase, as Julie said, projects that worked and had the impact of quality, safety, patient experience and staff experience, because that's what will make them sit up and listen. And I think that's a start. It's not the be and end all, Nicola, but I'm just thinking from my point of view, that's probably how I would do it. Thank you.
Thanks, Kaz. And I think it is that showcasing that's really important. As someone once said here, it's actually a midwife clinic academic. It's, you know, people often see research as the icing on the cake. And he said, no, it's not the icing on the cake, it's the recipe. And we have got so many pressure points in the NHS now. We can research our way out of it. We did with COVID, and research is crucial to answering those problems. It's not just a nice to have that can be left over on the side. Katie, did you want to add anything to that from your perspective?
I think probably just to give an illustration of what we do down here is, so as part of our trust, we have a centre for nursing, midwifery and allied healthcare research. And the chair of that centre, which is part of the trust, sits in the board level, so reports directly to the chief nurse. And so we do have a foot in that way to make sure that the research that is undertaken by all of those professionals within our organisation is actually discussed at board level. And we have a conference that we do every year, so where we bring together everyone that's doing any kind of project, whether that's QI, service evaluation, audit, and everyone gets an opportunity to meet and discuss and to share those. And so it very much puts it on the radar of our trust. So that's how we're trying to address making research part and parcel of what everyone does. It's just part of our job. It's just what we just do it. And that's the ideal. That's where we want to get to. I'm not saying it's without its challenges, but that's how we're trying to address it.
Thank you, Katie. And that sounds like a really good idea. And that annual conference, is that just around MMAP research?
Yes, so we have that. It's within the trust, and people can put in abstracts and posters, and we have all sorts of presentations. And to be honest, it's not just MMAPs, because a lot of what we do is multidisciplinary. So we might have people from all parts of the team that are there presenting, but it's just to show the different, or the breadth of projects that are going on within the trust.
Yeah, that's really helpful. Julie, did you wanted to jump back in?
Yeah, I think it just comes back to this point again, though, about capturing impact. And I was just come from a conversation with a colleague about workshops that we had been running to support people applying for the ICA schemes recently. So, these were the ones for the undergrad, the internship level and the pre-doctoral fellowships. And we were saying that we supported quite a lot of people, and not all of them even put in a submission at the end, rightly, for the right reasons. And then obviously only a certain number get shortlisted, and then only a certain number will get appointed to the scheme. And we were saying, but you put in so much time and effort around that. And actually, all of this work needs to get captured as a metric. It should be about measuring everybody who comes forward and has a conversation with us. And it should be about and we need to get better at capturing that interest level and that engagement. I think it's going back to what I had on that slide before about exposure engagement. So actually everybody who comes forward and has a conversation with us about research, that's important, because we are slowly shifting culture, and culture shift is really hard to measure. And so I think some of it for me is just about us capturing the work we do, and being able to share that. And I have had this, because I'm 18 months into a post, and you think, gosh, am I showing my value? And so I actually went back and looked at the stuff about money, because I think it's a financial investment in my post, and you want to show worth. But actually what I was able to show when I went back and looked at that is that my salary for the past 18 months, I've earned enough money for the trust to pay that. And actually, if you then look at the indirect costs, so everybody who's gone and won an undergraduate, not an undergraduate internship, an internship, that's £12,500. Some of the PCAFs are around £60,000. That level of support and investment you've done to those individuals, and you start capturing that, you realize that there's a large indirect benefit to having a clinical academic. Some of the grants that I'm on are worth £1.9 million. Now, and that's a trial that my unit is then taking part in. So they've employed research nurses. Our patients are getting opportunities to take part in research that they wouldn't have got before. So there's these indirect benefits, and we are not very good at capturing all of that. And I think, when you work in the university setting, they're much more set on metrics. But those of us working in the NHS, we're not always very good at capturing that. So I think we've got work to do to show what we're bringing to the table and how we're helping our patients and our staff.
And that is so well said, Julie. And I think that's true. And I think two things there about us nurses, midwives, and AHPs. I think we assume that we ought to do everything for nothing in our spare time, which we don't have. And I've had people get in muddles because they've taken on too much and they hadn't thought about backfill for their time. Medical students come out of medical school, and my daughter's just gone to medical school, and I know they come out primed, ready to find some funding to do their research, and we don't train our nurses well for that. So it goes back to what you're saying about getting the students involved early. But then when we do something, we're not very good at sort of blowing our trumpets and saying, look what we've done, look what we've brought in. And I think that probably is quite interesting, really. It's a cultural thing, and I think it goes with the nature of our natures, but we need to do that more to help others. And that is so inspiring. The hour's just flown past, and I was thinking we might finish early. I was thinking, I'm not sure how this is going to go. And I'm thrilled to see that it's 2 minutes to go. I'm just clicking this now. I've popped my email address in the chat there. If anyone's got any further questions for any of our speakers, or for Kath, who couldn't join us today, but she hasn't got a PhD yet, but she's on that pathway at the Royal Brompton. So anybody has got any further questions for any of our speakers, or for Nicola, who does so much in this field as well, please do email me. I'd be delighted to signpost you to help out where I can. it's been really good to have everyone join us today. So thank you. And I did the previously, and that sounds a bit like a Netflix thing now. And now I'm going to go next, sort of the next webinar. So we're going to have a month off in August, and then the next webinar is Thursday, the 19th of September. And that's going to be, again, moving on to picking up on some of the things we're talking about today, quality improvement and practical evidence-based practice in improving care. And don't forget, this all started with Florence Nightingale. She started, you know, in the Crimea saying, this won't do. What are we going to do about this? All these soldiers are dying. And she was a statistician. And this is where we've gotten now. And I think she'd be really proud to see lots of these examples that we've had today. So thank you hugely to Kaz, to Julie, to Katie for this. Thank you, Declan, for organising us all, for the music at the beginning. Thank you, Nicola, for being an inspiration and a mentor to me and for pulling this all together in the first place. And thank you to you all for what you do. Please keep in touch, and we'll see you all in September, if not before. Thanks very much, everyone. Bye.
Thank you.